Here's a short one. Yeah, it says, "Hi, Doc.
Oh, there you go.
I'm currently toward the end of a 12-week Ipamorelin CJC 1295 without DAC at 200 IUs each morning and night. 5 days on, 2 days off. I have received conflicting information on if I should take a 4-week break or continue to use the same protocol. Would you suggest I take a break? And if so, for how long? Thank you, George Rivero." So, again, I don't know why you're taking it or anything about you.
What is it that he's taking?
Well, this is to increase GH production.
Okay.
So these are two peptides that are working by two different mechanisms of action, one through growth hormone releasing hormone as an analog, and the other through the ghrelin mechanism. And I'm not sure though that's the correct dosage, but because 200 IUs, that's not the right measurement. But anyway, I'm assuming it's a proper dose, and that might be a good assumption. But the idea of having to take a break, we were just talking about this yesterday, as a matter of fact, with Empower Pharmacy. The only one that I'm aware of that requires a break is Peptide. Again, one of the original GH secretagogues. Used to be known as Jaref. They would recommend a 30-day break after 3 months.
Why?
And, well, you accommodate to it. So in order to get better results, they do this with a lot of different drugs. For example, in the weight loss field, we use phentermine as an appetite suppressant. And the body starts to get used to it, just like you do with coffee. You know, you wake up every morning, have a cup, and after a couple months, like, well, it takes two now.
Yeah.
So rather than doubling the dose and hoping for the most, what we'll suggest is just to come off it. And that's what they do with Peptide. And with Ipamorelin and CJC 1295, I have not heard of that being necessary. Again, to my knowledge, Peptide is the only one in which you need to come off. I do question the 5 days on and 2 days off. That sounds like artifact from the days of bodybuilders using GH for 5 days on.
I was just going to say that, so you can make the viral last a whole week.
I still to this day don't know. I've heard different theories, and I don't want to throw one out over the other because I don't remember all of them. But none of them made sense to me. It might have been something as simple as just it was practical, that it worked out that way based upon what they were getting in a bottle or a vial, I should say, and the total they were using for the week or whatever. Yeah. But particularly in the case of a secretagogue where you're telling your pituitary to make more growth hormone, why would you need to take a day off? Again, I guess I am going to spill the beans on one theory, was you took 2 days off so you let your body start producing its own again. Well, you're using a secretagogue here. We're not talking about exogenous growth hormone where you might be suppressing it, so there's no need to take 2 days off. You're continually telling your body to produce more. So
they may not know that, though.
That's part of why we're doing this, right? Again, so I don't follow the rationale to take 2 days off, but in either case, I don't believe there's a need to take a break. Again, we were just discussing this yesterday with a pharmacist at Empower, so to my knowledge, no need to take a break. Again, that was back in the Peptide days. And, you could, if you notice there was a lack of efficacy, although I haven't heard this either, where someone gets accustomed, the body accommodates to use of one, and then you try another and it starts to produce more again. For example, if I see someone with great assays after, IGF-1 assays after starting Ipamorelin, I see it indefinitely. I don't see a downturn because they've been using it, say, for 3 months. That's my point. Now, if you start misusing it, all these require that you stop eating within 2 to 3 hours of bedtime, roughly, depending upon your body type, and if we're talking about a normal-sized dinner or a Jethro Bowl-sized dinner, so it's very important that you not compete with your own production of growth hormone when you're trying to stimulate its production through these GH secretagogues by increasing your blood sugar and therefore increasing your insulin in reaction to that, because insulin, and I'm going to use the word compete, but that's not fair because it absolutely destroys, the competition in terms of competing for the production of growth hormone. So If you've already got insulin being produced because you just ate a big old cheeseburger and fries before bed, you're kind of wasting your time using a GH secretagogue. So you got to be disciplined about your use of it. And the best time to use it, by the way, is at night. Why? Because, again, we're not overriding the system here. I mean, in some ways, obviously we are, but we're trying to encourage it. So you want to encourage when your natural production is at its best. Okay, yes. Arguably. Because some people say, well, if I'm just going to ride what's being produced naturally about an hour after you go to sleep at night, particularly during deep sleep. And then I'm going to try and get some more produced in the morning. Okay, that's a theory, but typically you want to go ahead and you'll get more bang for the buck if you encourage what's already being done naturally, nice. In this case. So, again, right before bed, and particularly with something like, not with Ipamorelin, because the ghrelin pathway, for whatever reason, with Ipamorelin, you don't get as much or any of the hunger side effect, but with ibutamorin, oftentimes you do, like the GHRP2s and 6 we talked about earlier. So right before bed, not, let me see what's on TV for a while. Otherwise you'll get
so hungry and you'll eat again.
Yeah. Exactly. Most people fall asleep in 12 to 14 minutes, whatever, sometimes sooner, sometimes a little later than that. But you'll sleep through any hunger if you do it that way.
Right.
Okay.
So technically, based on what you're saying, you shouldn't be having a meal right before bed, especially if it's rich in carbohydrate. But could you have a meal with some protein and fats? That's not the same. That wouldn't spike your insulin.
It would probably be better for just that reason, exactly, because you wouldn't have such a spike in sugar because it takes much more to, particularly fats, to break it down and get some calories out of it. Proteins, not as hard to digest as fats, but certainly carbohydrates, much, especially the simple carbohydrates, right, like the white rice or something like that. That's going to go in way too quickly and spike it. Now, here's the only counter to that is, okay, depending upon your metabolism, this is why, all this, we'll never be out of a job as physicians because, unless they change the laws, everyone's different in your metabolism, for example. You might find that if you have your Jethro bowl full of rice, okay, you get that spike. But by the time dinner rolls around, you've already dropped down again, a sugar and insulin spike, so that you might be actually hanging kind of low when it comes to insulin and might be perfectly poised for now your dose of ibutamorin with no competition from insulin.
I know, but if you're talking to a bodybuilder, they'll eat 5-6 meals a day, which means that most of the time bodybuilders will have their last meal right before bed. So for that reason, if they're using that, I would say if their last meal is only comprised of protein and fat, it would still be okay for them to use it.
It's better. I'm not going to say it's okay.
So you'd rather them to be empty stomach, ideally.
Yeah, because, again, we're trying to manipulate the hormones. Okay. And I would argue that a lot of the stuff that gets passed down, okay, think about the bodybuilders, historically, they're using exogenous GH. So they're overriding the system. They don't care what is produced by the body.
Yeah.
They're saying, I'm going to have this right before bed, and I'm doing my exogenous growth hormone. Just like they will use insulin, not just, but similarly, they don't care because, again, we're not dependent upon the body's own production. Now, they've done some studies on this. Actually, I say they in studies. I remember reading one where it presented a pretty good case for missing the meal, okay? And so maybe instead of 6 meals, having 5. Or front-loading those calories earlier in the day so you have that ability to drop your insulin. Because the hormones, which guys will go to great lengths to get those, whether they're naturally produced or synthetically and anabolic steroids, etc., do such a great job. You want those to be there. And one of the arguments actually also in something I read was, you hear about post-workout, boy, stop the catabolism right away. As soon as you're done with workout, start eating something so you stop that. Well, there's a lot of processes that occur post-workout that you may not want to stifle by having some calories right afterwards. Some of it, related to hormones, some of it related to perhaps autophagy, when your, NAD levels are up high. I mean, I don't want to get too off course here, but, this is where it comes down to, again, so often one size does not fit all. And this also, I think, makes athletes and champions what they are because they learn to use certain things as a general guideline, but then they tweak it to what they figure out on their own. They go, okay, that might work for most people, but I know it works for me.
Yeah.
I'm going to try, 2 hours before bedtime or 4 hours before bedtime to see what works best for me.
Yeah.
And that's, my advice to anybody.
Yeah.
As long as you know you're not going to do something to harm yourself, experiment, find out what works best for you.
Fine tune. Yeah. Awesome. That's a good answer. Okay. Thanks, Doc.
Yeah,
All right, Doc, you didn't delete the page. Okay, cool.
All right, next question. Hello, doctor. Sir, I am from India. I am a teenager of 20 years of age. I've been working out for past more than a year, but could not find good results. Basically, I have seen people at my gym who take anabolics and just come to pump their body, and they seriously have an influence on me doing heavy lifting and still not getting results. Sir, you are very well aware that how teenager gets attracted to such things, but problem is they can't ask this stuff to their parents, etc., particularly here in India. I seriously want to get the best shape, but also don't want something wrong to be injected into my body. Like there are some bodybuilders here in my gym who are trying to sell me. As you might know, this kind of manipulations, but genuinely I want a reply from you. Please suggest how I should proceed. Like what cycle should I start, and what if there's any other alternative or anything. Also, I do want my height to increase further, as these are my growth years nearby ending terms. So before my growth plate closes, I really wanted to consult you. Please guide me. Regards, Cater. So again, Cater, I apologize, but this is something that you should definitely visit your doctor over. I can only give you some general guidelines by which maybe to proceed and suggest, again, with the help of your doctor. But first of all, 20 years old, you shouldn't expect at any age to be competing with someone in the gym who's taking anabolic steroids and eating right, sleeping right, training right. You're doing, I'm going to assume, all the right things in terms of that. Again, eating right, training right, sleeping right. But without the leverage of the anabolic steroid, even though you've got 20-year-old testosterone flowing through you, it's not the same. Depending on what steroids they're taking, how many milligrams of each, etc., they could be leveraging what you're doing at a minimum threefold, maybe tenfold. So it's just comparing apples and oranges. And don't be discouraged by that. Just realize that your day will come too, if appropriate, when it is appropriate. And it's not at 20 years of age. If your concern is growing, then yes, from what we know about the way growth plates close, etc., you don't want to interfere with that and stunt your growth by introducing anabolic steroids or any sort of treatment, before it's time. If I don't have any numbers here for height and weight, but if you are short in stature unnaturally or undesirably, whatever, that's something that you want to address with your physician, because at 20, quite frankly, even though, again, I was taught 26 is pretty much the cutoff, it's a lot harder to get you to continue to grow the long bones, to which he's referring, where you have these end plates, once you get into your 20s, for sure. So that would be, if there's an issue with the height, I would address that forthwith with your doctor, if that's the issue, or one issue. As far as putting on weight, take your time. Right now, even if you got on an anabolic steroid, the likelihood that you would injure yourself would be pretty high, because you're still growing. You haven't put in the miles, less than a year working out, more than a year, I beg your pardon.
Just getting started.
Yeah, your muscles will grow much faster than your tendons will strengthen. And so if you progress too rapidly with muscle growth, you'll end up injuring your tendons, whether it's through what eventually becomes chronic tendonitis or a frank rupture of the tendon. So I know, it seems like a long time, and I know I sound like, if not my father or my grandfather, take your time. Wait and think of the long haul, and you'll be better off. But I would address the issue with your doctor, and let's get laboratory assays to see. Maybe it is more than should be the difference between you and those that are on anabolic steroids, because there may be an issue where you have low testosterone. Who knows? But these are things that you might be making some assumptions here, and let's not make assumptions when, I always say don't guess when you can test, right? So let's get some labs and see what's going on. And yeah, don't inject things into your body, particularly if it's not prescribed. I know a lot of guys who might have in their lifetime taken things because they were willing to take the risk and didn't think it through, that were made outside of a pharmaceutical manufacturing plant, but it's not the wise thing to do now or in hindsight. So not something I would recommend there.
Well, what age would you say is the maturity age as far as height? So you say the axis is fully formed at 26, but as far as height, when would you say, okay, past this age, you're not going to grow taller anymore?
Yeah, like I said, when I was going through school, the age they gave was roughly 26.
Really? I thought it was 18, 19.
That's when they say you stop growing.
Yeah.
Right? But I had a patient, short in stature. We tried growth hormone in the 20 and 21 years old time period. We got no results.
Really?
It already, the growth plates apparently had already closed.
Okay.
And, look, this is an N of one that's in my practice.
Yeah.
Okay. But you hear, what's going on out there. You definitely want to get it earlier rather than later. Better in the teens, certainly. If you can identify it earlier, all the better. The problem with, age 20 is then you're also guessing. You don't want to overdose. And it's kind of weird because the younger you are, believe it or not, the more growth hormone you need to get results, and the older you are. So you're in this weird area.
Yeah.
Okay, how many IUs a day do we use? You don't want to overdo it, and they sprout too much, but you don't want to underdo it because time is ticking. And here you are, 3 months, 6 months, and now you're 21 instead of 20. So earlier is better. But again, at 20, let's see what's going on. And again, I might be making some up. Maybe he's just concerned about stifling that last little bit of growth he might get, and makes a good point of it, but he's not necessarily short.
Yeah.
I don't know, Kadar, but anyway, trying to address as much as I can, making some assumptions here or some different scenarios so I can give as much information to you as I can. Again, information, but again, most important thing, I would address this with a physician, and I realize that there are different physicians of different qualities anywhere and everywhere in the world. Here in the United States, for sure, we have pediatric endocrinologists, although, in this case at 20, you wouldn't be pediatric anymore, but we have endocrinologists, and this is their specialty when it comes to stature, height, and use of growth hormone, that, if this is an issue, we should be able to address it. And then, get the labs for your other hormones to see where you are there, if it's not a height issue, or it's just a matter of putting meat on your bones. And don't forget some of the basics. Again, this is where you want to really address it with an expert. And I know you obviously are trying to, not to suggest I'm some special expert, but again, without more information, there's only so much that I can suggest to you. So I would dig into it a little deeper. It sounds like you're frustrated, so you definitely have some options to investigate and go from there.
Awesome. Thanks, Doc. All right.
Boy, a lot of young people on this one. It says, hey, Doc, love your vids. I'm 19 years old, and I basically have malabsorption issues. So stunted growth and delayed puberty are issues I've always had. I've always been smaller, and basically, even now, I don't believe I'm fully matured. Tic-tac balls, laugh out loud. That's funny. I have recently gotten on HGH every other day, 10 IUs. Okay, see, that's a hefty dose. Yeah. Boy, interesting how this comes up 2 months
all the same
ago.
month. That was funny.
Yeah, right? And I've decided to get on TRT. It's a huge decision, and I know it will be for the rest of my life, but my bodybuilding just doesn't produce enough testosterone. Or my body, just doesn't produce enough testosterone on its own. I am taking a certain mixture of testosterone. I'll attach a photo. I'm taking 10 units in an insulin syringe. All right, so he's marking that. So a day for 5 days, which calculates to about 200 milligrams of test cypionate/enanthate, I'm guessing, he writes C/E a week, or 140 milligrams of actual test a week. All right, I'm a little confused with that. I'm also taking this with 10 milligrams of aromacin daily, mainly because studies show it helps in conjunction with HGH for growth. Lastly, I have Anadrol 50 milligrams,
oh boy,
which I have been taking for like the 5th time, which I want for my anemia and lack of weight. I am about 5'7" and weigh 100 to 110 pounds. I would compare my puberty/biological age to a 14-year-old boy. Any suggestion would be appreciated. I have already tried the Clomid HCG combo to try to get my balls bigger than with the small little Tic Tacs. Funny, I appreciate the self-deprecation and the humor. I have, but it didn't do anything sufficient. I 100% agree with you on the Clomid. It made me want to die. I was crying like a little girl who just lost her cat. Love you all. All right, so we got a humorous one here. I love it. So thank you for your question. One issue here that is probably circular in nature is the malabsorption leading to, the endocrine issues. Stress is a big factor in terms of your body producing the right amount of hormones. And one that's really easy to identify is thyroid. We actually have a term called sick thyroid. If you're under too much stress or literally sick with a virus or bacterial infection, your thyroid production typically drops, and it's referred to as a sick thyroid. Here, I think it's probably furthering the lack of maturity of the development of the HPA axis, and then perhaps the growth of the testicles. I'm assuming that they have dropped, so we don't have another issue there. But sometimes the testicles, which start up inside the called the abdomen, but inside the pelvic area, none of us remember this because it happens at a relatively early age, but eventually those testicles drop into the scrotum. Sometimes they don't drop, and sometimes that can be an issue. But anyway, I don't want to reach too much as to what's going on, but it can affect the steroid hormones and the peptide hormones, meaning, the testosterone and the growth hormone. And again, it sounds like he's on a decent dose. Like I said, for 10 IUs a day for most people is arguably triple the replacement dose.
Wow.
But you can, because he's younger, that makes sense, as I mentioned earlier. Going on TRT, again, I don't know enough about what's going on here, but I'm suspicious as to what's going on when you tell me you tried HCG and the testicles didn't respond. That's primary hypogonadism, we would call it. Typically at this age it's secondary, meaning testicles are working fine, they're just not getting a signal from the pituitary to do anything. So you provide that signal through a homolog of LH called ACG, and you get wonderful results. So then I question, have to ask, especially with some of the people that are writing in here. I mean, was it from a pharmacy? Do you know it was HCG? What was the dose of HCG?
Yeah.
Because it's pretty foolproof, but it would certainly help with the diagnosis to find out if it's primary or not. And then, if it's primary, you have no choice but to use TRT to replace it rather than try and coax your testicles to produce it. In which case, you might always, if I might borrow the term that you used, have Tic Tac balls. Sorry, I mean, the testicular atrophy. But this might not even be atrophy. I mean, I wonder a question that I would want to ask is, have they always been small, or have they shrunken since,
right?
I don't know, age 18 or whatever. So a lot of questions to ask here, but the replacement dose sounds weird too. 140 milligrams a week is awfully light in my experience. Typically 200 milligrams a week is a starting dose for most men, no matter what the age. But again, through first feedback to see how you're doing, and then in combination with laboratory assays, maybe that is working for you. The Aromasin daily is a good idea, obviously, to prevent conversion of testosterone into excess estrogen. I don't know of any study talking about the use of Aromasin helping with human growth hormone. So I apologize. I'll have to do some research and get back to you on this one. It's the first I've heard. But again, if that's something you're after, then all the better. Aromasin is a good We call it a suicide inhibitor so that it again, blocks that conversion of testosterone to excess estrogen. The anadrol, again, this jives, obviously, when you have malabsorption issues, you can often have problems with anemia, and anadrol is indicated for anemia. I have never in my life written a prescription for anadrol, even though it is a legal steroid, anabolic steroid that can be prescribed in the United States, and one of its indications is for anemia. Not all anemia, but I think it's pernicious anemia. But at any rate, one of the side effects is, it can help you put on mass. It's I've talked to colleagues who have written for it, again, rarely, but it's for that really difficult case of someone who's got malabsorption, can't put on weight for any reason. And again, I've never had to use it, but...
Isn't that toxic for the liver, though?
Not necessarily. I mean,
No?
We talk about toxicity in the liver for all of the oral anabolic steroids. It is tougher on the liver by nature because it's part of the GI tract. You have to ingest it and it goes through what we call first pass. But, so is a cold beer.
But not any more than other compound like Ganavar or anything else? Same?
No, there are some. For example, one legal anabolic steroid, I think it's still legal in this country, that I've never prescribed because I can't imagine why you would ever prescribe halotestin.
Oh,
but
yeah.
That one is definitely
toxic,
hard
right?
on the liver.
Yeah.
And methylated testosterone. The idea being that you're kind of robbing Peter to pay Paul. You're trying to make it so that the liver doesn't metabolize into something that's not useful to you and then get rid of it. You're trying to preserve the drug. You want to be what we call a cheap date with the drug, right? So you don't need that much. Well, the problem with that is the liver wants to do its job, if you will, and you're making it harder on the liver by making it stick around, and that is what we would refer to as, toxic to the liver. I guess.
see.
And no, as far as I know, anadrol isn't any more problematic than, say, like I think you mentioned oxandrolone, Anavar. It's just, it comes with some estrogen-like symptoms. We don't know why it does this, but the same moodiness and irascibility can often rear its head with anadrol, even though it supposedly doesn't convert to estrogen. So it's an interesting one, but might be apropos here. 5'7", 100 to 110, that I think in anybody's book would seem kind of light. So anyway.
110. Jeez.
As far as suggestions going, I would submit that probably anything less than 3,000 IU every other day of HCG would not be a sufficient trial. That's max dose, but that might be something that a 19 or 20-year-old would need in this situation to see if indeed the testicles will react, and again, differentiate between secondary versus primary hypogonadism. So, let's make sure that avenue's been exhausted before you switch to TRT, because then you're committed. You can always go off TRT, just like a female can go off birth control pills, right? Obviously the point being that you're squelching your own production, then you stop taking the birth control pills and they come back. Same here with testosterone, but at such a young age. And this is something again, for the ladies who gave us no questions this week, right? It's not talked about too often, but I would not prescribe birth control pills to anyone, any female under 26 years of age, for the same reason I wouldn't want to do this either. For
that's interesting.
To wait until the HPA axis is fully developed. No, there are some studies out there. You don't hear them because I believe the argument is, well, we don't want to have motherless or fatherless children, or have babies born long before their parents are ready to provide for them. That's a worse problem than perhaps messing with the HPA axis. Wow. The studies are out there. Again, and I know a lot of women who've taken birth control pills since they're 16 and had kids, but just like post-finasteride syndrome and some of these other situations, it is possible for that to disrupt the formation of the axis. So it's not something I would recommend. So in this case, if you can avoid TRT, let's see if you can. It's also harder to get to remain fertile and to restore fertility at some point down the road if you've nipped it at such an early age. So, look, I realize it's not pleasant. But there are other issues driving this, obviously, the malabsorption. So instead of the Clomid, the other comment I would add is try enclomiphene. We have that available here. I don't know where this gentleman's writing from, but it doesn't include the other. There's two isomers in there. One of them is zooclomiphene. The other is enclomiphene. You want pure enclomiphene. The zooclomiphene is what we suspect gives the Clomid, which is the two combined, that nasty, what do you say, crying like a little girl who lost her cat and just feeling horrible. So those are some options. I wouldn't give up, again, unless I had some of these questions answered fully, before you stay on TRT. So I hope that's helpful.
Yeah, awesome. Thanks, Doc.